Welcome to the ongoing conversation and discussion on Ozempic. And today we're focusing on nutrition. We'll take a moment to allow people to join us from the waiting room.
Yes, and while we're logging on, feel free to go ahead and place in the chat where you're logging in from, what specialty you're in, what brings you here today. We will be recording this webinar to send over the replay to you. If you are here, you have successfully signed up for the Balance webinar, Nutrition, the Ozempic discussion. We are thrilled you can join us and really appreciate you taking the time out for today. Now, if this webinar helps you or your practice, it would mean a lot to us if you would leave us a review. Balance is a premier eating disorder treatment center offering boutique outpatient treatment options using evidence-based practices. We'll talk more about program offerings and how to get in touch with us for referrals after the slides and discussion piece towards the end of the hour. And welcoming in our host for the afternoon, here we have Balance founder and CEO, Melainie Rogers, who uses she, her pronouns. Melainie is a certified eating disorder registered dietitian and supervisor, as well as the founder and past president of the International Association of Eating Disorder Professionals for the New York City chapter. At Balance and as a professor in the Department of Nutrition and Food Studies at NYU, Melainie uses her experience to provide guidance to students, clients, and clinicians new to the field of eating disorders. Leah Graves, our co-host here, is the principal and founder of Graves Nutrition and uses she, her pronouns. As a certified eating disorder specialist supervisor and a fellow for the Academy of Eating Disorders, Leah brings decades of experience with a specialized focus on eating disorders. As the principal of Graves Nutrition Consultancy, Leah combines her expertise with a warm, collaborative approach to support organizations and professionals in delivering top-tier behavioral health nutrition care. Now I'll pass it over to Melainie, who will lead us through the bulk of the information here with Leah, followed by our Q&A and discussion.
Thanks so much, Alina. Hi, everyone. It is so lovely to see you all today, and welcome to this very important discussion on body image and an Ozempic and our weight loss medications. And today we're going to specifically be focusing in on nutrition and what do we need to do to support our clients who may be going onto these meds, have been on these meds and are coming off them, or are already on the meds and then come in to see you as a clinician. So threading that needle, navigating nutrition care and the GLP-1 RA medications in eating disorder treatment. And I want to give a particular shout out to my colleague and friend, Leah Graves, who's joining me today and sharing her exceptional knowledge on this topic as well. So firstly, just disclosures, Leah nor myself have any financial relationships to any of the studies and such that we will be presenting, unlike our pharmaceutical companies, which have a lot of conflict with some of the research because they're funding it. So let's go to our next slide.
All right. So thank you, Melainie. I'm so excited to be here with the Balance team and to begin this dialogue with each of you today. Melainie and I really want this to be the beginning of really critical conversations. And we wanted to start by laying a foundation to give us an idea of just who is getting Ozempic and or any of these GLP-1 receptor agonists, or now the GLP-1 GIP receptor agonists, which are tirzepatide is probably the one that you're most familiar with. According to the Kaiser Family Foundation, and this is our most recent data, and it comes from 2024, about 1 in 8 or 12 to 13% of US adults have used a GLP-1 receptor agonist. So they are here, they are present, and I would offer that this data is outdated at this point, and it's probably significantly higher, but this is what we have to work with today. It's just to lay a foundation to understand how prevalent these medications are. And you've probably noticed that from media, right? As we began to have this conversation, right, of, okay, what does this mean for us as dietitians, especially those of us working in the eating disorder space who are really interested in weight neutral medicine and some of the things that we hold dear as values. But the reality is we're going to see people. And we got to thinking, who might be presenting to our practices. We had 3 groups that we thought might be prevalent presenters. You probably have had experience with others, and it would be great if you have those to add them in the chat as well. But we were thinking that we would probably have current clients who wish to initiate, or they've had a recommendation to initiate a GLP-1 medication. We might have clients who present to us who have been placed on one of these medications. They're not happy with how that's worked out for them, and so they present to care. They're disappointed with results. And then we thirdly might have clients who've had dramatic weight loss or significant impactful side effect profiles, and they present to care for us because they're worried about their nutrition state. And all of those I would offer as eating disorder registered dietitians. We are really in a great position to help. So the question is, what do we do, right? And I don't know about you all, but I like to be a little proactive. And I know Melainie and I are thinking, like, how are we proactive with this rather than just responding? And when you think about it, there are several ways as dietitians we could respond. One way is to say, I'm not comfortable with these medications, therefore I am not going to choose to see individuals taking them, and I will do one of 2 things. I will refer them out if they're currently in my practice, or I will politely decline to accept them as a client. And then there's a third option that Melainie and I thought of. And the third option is to join them on their journey and see how we could support them as they tried this novel new approach to treating many illnesses, not just weight management. So we're going to spend the bulk of our time today on how would we join someone? Because the other 2 have an easy answer, right? We just don't engage. But how would we engage with clients? So as we see it, dietitians with expertise in eating disorders have a real opportunity here to impact the focus of GLP-1 care. We have some unique skills that we bring to bear that actually could improve the quality of care for everyone, I would offer, taking one of these medications. The first thing that we have is that we have the capacity to actually understand the risks and challenges of using one of these medications in the context of a client's eating disorder or disordered eating behaviors, because all of the side effects are going to be related, as we'll discuss later, to one's ability to eat. Secondly, we have skills. You have skills. You were trained in state-of-the-art nutrition assessment, monitoring, and you have the capacity through some of our modalities to actually monitor strength and functionality for patients. So that is a skill set that is not present for other members of the healthcare team. Thirdly, we can identify emerging or escalating eating disorder behavior in a client very quickly. We can detect and address side effects early because we have good counseling and relational interaction skills that allow a client to be able to tell us things like that, but also that we can read between the lines and notice things and inquire. And last, but certainly not least, we're going to spend a little time later today talking about how might we shape how these agents are used and the care of these clients from the inside by collaborating with the prescribers that they have.
Thanks so much, Leah. And so that brings us to the first category, which is looking at what are those risks and what are those challenges. So nutrition risks that are present with initial initiation. We're seeing compromised effectiveness of nutrition and interventions for the disordered eating or eating disorder due to the focus on weight. As we know, when our clients are focused on weight, it's counterindicated to our treatment, where treatment is about consistency of food intake and consistency of nutrition for the body. Compromised client nutritional state, both prior to initiation of the GLP-1 RAs and certainly afterwards. Other risks is the client feeling caught between nutrition paradigms, and we're going to look at that in more detail. And then also client confusion regarding treatment targets and goals. You know, the doctor tells me I should be losing weight, but the ED team is saying, no, 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 we don't want you doing that. Those specific challenges then Firstly, evaluation of the nutrition state of clients at initiation of the GLP-1 RAs. So when they're starting, what's the baseline? Number two, weight loss that then is experienced on these meds includes, very importantly, loss of lean body mass. And we're going to go into some details there. We know that with that, there's a loss of strength and there's a loss of functionality in the body. Three, we want to be able to identify and manage the side effects of these meds and these differing paradigms between the PCP, the MD, and the ED team among those stakeholders, the client, the medical provider, and us. And then, of course, monitoring the nutrition state of our clients during the use of these meds where they're at very high risk for malnutrition.
So we're going to dive into each one of these challenges individually. So let's start with the upfront, as Melainie said, like getting the baseline. And what we want to point out for the dietitians on the call, this makes total sense. You know, the first step in the nutrition care process or how people enter is through a nutrition screening process. We felt it was important to take a look at, you know, what is the baseline for that and how does that work, right? And so the reality of the situation is if a client is not in a hospital setting, they are not being screened for nutrition risk. And even if we were to take the tools that are used in hospital settings on a daily basis, right, in healthcare settings to screen, there are some huge problems with that. In that nutrition screening as it sits today, we do not have very high science quality or validation on these instruments. So they're really not as effective as we'd like them to be. And honestly, they're really focused on unintentional, and I'm using my air quotes there, some little fingers go up, right? Weight loss. They're very weight loss centric. They're only looking at weight, not other parameters of nutrition state. Like appetite change and acute illness. Outcomes are highly variable as well, depending on who's delivering them. And depending on what healthcare setting you're in, they may or may not be delivered by registered dietitians who are the most skilled to do so. So the reality of the situation is that I think referral to dietitians is for actual assessment, like we do in eating disorders, right? We do not screen clients, we assess all the clients. And we're suggesting that assessment is really where these clients should sit, given the risk of these medications. So when we look at the nutrition state of individuals who are seeking weight loss, we do have some data. I have a lovely citation here, and it's in the bibliography as well. And what is challenging for us that we've all known for quite some time is when you survey or you work with individuals who are practicing in the weight loss, weight management space, often malnourishment is only considered an issue for low weight individuals. They're not looking for individuals who might be at a different part of the normative bell curve spectrum of human body shapes and sizes that may have nutrition deficits. And so what we do know, though, is individuals who seek weight loss often do have significant malnutrition that needs to be addressed. And there are many factors that contribute to that. All of them are things that we as eating disorder professionals actually assess for as a part of our process for care. Some of them are environmental, like food security. Others may be related to diet mentality, like low nutrient dense diets. And others may be related to the weight loss itself with restrictive eating patterns, muscle loss, and vitamin and mineral deficiencies. But all of those add up to individuals with poor nutrition state, which is a concern when you layer on a medication that's also going to have the impacts that this new class of medication does. Now that we've been negative, right, we want to offer some hope here, because the reality of this situation is, as dietitians, we have tools, and we have tools that are not specific to eating disorders, which I view as a strength in this situation. So the Academy of Nutrition and Dietetics and the American Society for Parenteral and Enteral Nutrition have collaborated on consensus criteria for identifying and staging malnourishment in adults. And this supersedes across all illness categories, includes environmental factors, all kinds of things. And we can use these factors, this assessment tool, as we're doing our nutrition assessment to identify and then stage malnourishment in our clients. And listed here for you are the things that we're assessing as a part of that. And we're going to slip into the next slide so we can look at what that looks like. So what I did is Melainie and I sussed out those 6 categories that you need 2 criteria for, and we put them simply in this center category here. So we're looking at our clients to see how is their energy intake, have they sustained tissue loss, weight loss, and what are some physical findings that might be present in the client. I put here for you what the criteria are for severe malnutrition in chronic illness. And the reason I put that is because an illness that is lasting more than 3 months is considered a chronic illness. And as you know, most of the people with eating disorders that cross our threshold have been engaged in their behaviors for longer than that. So what we're looking for severe malnourishment in a client that, say, has disordered eating or an eating disorder and is considering any one of these medications is eating 75% or less of what we determine their nutritional energy needs are, recent weight loss of more than 5% at a month, and the other subsequent values. You'll notice those align with the risk of refeeding syndrome beautifully if you look at the De Silva data on that. So bear that one in the back of your mind. And then physical findings like loss of subcutaneous fat, severe musculature loss, fluid retention, especially edema around the feet and ankles, and measurably reduced grip strength. What you see in the right-hand column is what that might look like on an actual patient that comes through the door. That could mean a patient with energy needs of 2,500 calories a day, which is not an outlandish amount of energy need for a somewhat active adult. They only have to restrict to 1,800 calories a day. They only need to lose 15 pounds in the first month. They may have orbital wasting or wasting at the temples as well, or that edema that we talked about, which often you're seeing in social media being commented on, especially amongst celebrities, as Ozempic or Wegovy face. Those are not high bars for folks to meet. So we're respectfully offering that a lot of our clients may actually be meeting these criteria during their treatment. So we feel like one of the tools in addition to those guidelines is to really rely on our standards of professional practice. And when you look in that document, it includes nutrition-focused physical exam. And that is a part of assessment in nutrition. It is a physical exam for those that are not dietitians on the phone call, where we actually lay hands on a client that is within our scope of practice. And we look for indicators of malnourishment by examining people's skin, their bony prominences, taking a look in their mouth, and also assessing other parameters as listed here. And one part of NFPE that I think is going to be incredibly useful for this particular group is on the next slide. And that is dynamometry or grip strength assessment. So one of the cool things about grip strength assessment is that it is a low cost, non-invasive, easy to learn to measure and become proficient at tool. I've listed an article here on how it may be used so that anyone interested in developing skills for that can actually gather that information for yourself. But suffice it to say that if we measure grip strength serially throughout a case, we can actually detect decline and feed that information back to prescribers who don't want strength loss, who don't want lean body mass loss, but aren't really looking for it. So as we started to think critically about this tool we have, one of the things I was curious about is, what do we know about lean body mass loss for individuals who are taking these medications for weight loss purposes? And our next slide is going to give us a whole lot of information on that. We're going to focus you on one small part. We're going to focus on the purple. What I'm going to tell you is what we've done is put together a table for you that provides side-by-side comparison with references, and you have full references again in your bibliography at the end, of very low calorie or liquid fasts, basically, behavioral weight loss as we know it, moderate calorie deficit with activity layered on, semaglutide in the STEP study, and tirzepatide in the SURMOUNT studies. I went ahead and put tirzepatide with resistance training at the bottom. It makes it look like there may be a preservation of lean body mass, but that study was done with literally no assessment of nutrition intake. We have no idea what's going on there, so we can't compare it to the others. The other studies, the semaglutide and the tirzepatide, those two, you need to understand included calorie deficit, moderate calorie deficit, and exercise. So they're basically behavioral weight loss with the medication layered on. And what I want to point out that's a lot easier to see in this next slide is, or graph for you, there is no difference when you look at the behavioral weight loss, the tirzepatide, and the semaglutide. The meds are not protective for weight loss. At the end of the day, the semaglutide study actually had a much higher loss of lean body mass. I'm very curious to see how that holds up in subsequent studies. The reason you don't have a lot of references is they're not really looking at this, okay? They're not measuring it. And we weren't willing to include anything that wasn't done by DEXA or a very reputable body composition measurement. So that data that you have is what we've got to date. That's it. Sorry to say, but wanted to have a visual for you to say we're worried about lean body mass loss for sure. So the grip strength might be a good option for us in helping to have a non-invasive way to look at that.
Thanks so much, Leah. And just to comment on the significance of that lean body mass and the fact that these meds are not protective of minimizing lean body mass is, should a client come off the meds, what we know is that when you lose more lean body mass, up to 40% we saw there, your weight regain rate is higher. And when you regain weight, you lay down or you regain more adipose tissue or fat tissue than you do muscle. What that means is what we see with yo-yo dieting is the client will therefore end up at a higher weight than when they started on the medication, and their body will be a body composition with more body fat and less lean muscle. And we know that actually that's where the medical complications and risks start to be far more of a concern, because that original body composition has now changed in what we know is a negative way. So that's the significance of that very, very high rate of lean body mass. And we actually saw this also with the Biggest Loser. And they followed those competitors 6 years later, and they saw that after 6 years, their metabolic rates had not recovered. And that, if you remember that horrendous show, they had them doing 6 hours of exercise a day, thinking that that would preserve the lean body mass, and it did in fact not. So, you know, and these are meds that you need to stay on for the rest of your life, and we don't even know what that's going to mean. And we also know that with any other medication ever, there is a slow but eventual weight regain over time, even when you're on the meds, meaning that they may lose their efficacy over time. So, you know, health risks are at the end of that, pathway, excuse me. So on to, therefore, as RDs, what do we got to deal with here? Now, the key thing, as many of you know, with semaglutide and why this medication is changing the game, so to speak, changing the landscape, is because it has two sites of action, not one, not just one. Most weight loss meds have had an impact on the GI. They slow down absorption, they slow down the gut, you feel fuller for longer, you may feel a bit nauseous, etc., because of that slowing down of motility. However, what these meds also do is they cross the blood-brain barrier and they have an impact on the brain. And that's what's making them so different, in their efficacy, and they're actually changing food preference. And you may have read some of this. People are moving away from high-fat foods and they're moving away from high-sugar foods. So that is significant and interesting. I'll put a question mark on it because we don't want to throw the baby out with the bathwater. You may have already heard also that it turns down food noise. I will say, though, that with respect to food noise and that constant jitter in the mind around food is a result of undereating. So I see that as a symptom of undereating and not something we should be less looking to as something to cure. But I'll put a pin in that as well. So anyway, let's have a look at these very specific side effects that are quite debilitating, and up to 30% of people cannot actually tolerate these side effects and are coming off the meds. But others are tolerating them. So we've got, of course, nausea, vomiting, diarrhea, constipation, gastric mobility, gastric emptying, hypoglycemia. And we know that tolerance, digestion, and absorption of food and fluids are significantly interrupted. I was just speaking to a restaurant consultant earlier today, and they were telling me that as a result of the significant difference in people's food choices, particularly fast food chains, they're now modifying their menus in order to work with the GLP-1 clients, which, it tells you how pervasive this is. As Leah was sharing the stats earlier, that's a pretty significant percentage of the population who are using these in order to, have such an impact on the restaurant industry. And so the differing paradigms. So we've got nutrition targets from the MD and the client, and they're saying we want weight loss, we want metabolic health, of course, we want cardiac status risk to be low, of course, all good things. But and let's be didactic here, and us in the ED world, we're saying, okay, that's great, but we want safety. We want you to not have malnutrition. So we want to look at your nutrition state, and we certainly don't want an increase or a development of eating disorder behaviors as a result of these meds. Take it away, Leah.
So the challenge is for our clients, right, that they feel like paradigms are at odds and they feel caught in the middle. As Melainie and I talked about it, we feel like there's some areas of commonality, which are going to show in the next slide. We're going to impose where the common ground is in the middle, that do address things that are of importance to both teams and allow the client to feel a more united approach to care. You'll notice those first four on there: hemoglobin A1C, avoiding hypoglycemia, blood pressure vitals, lipid levels are all related to metabolic risk and health risk, cardiovascular risk. And additional, we all want our clients to have strength, mobility. We don't want them to be suffering from an eating disorder, even disordered eating, and we certainly want them to be at a nutrition state that supports longevity. So those are areas where we all agree. Weight loss is one where we don't, but we can, as professionals, focus on how eating disorder behavior impacts these other. And our next slide gives you a great visual of that you can actually use in your practice to refocus why disordered eating is so important to address. So what you see on the left are some eating disorder treatment targets that we all use every day. I know we've got therapists on the phone too, on the webinar too. So we're all working together in that area. And on the right, what we have is what we know scientifically happens when we manage these things on the left. When we are nourished, when we are addressing eating disorder behavior, when we have supportive and joyful movement, and when we are improving our coping strategies, we see improvements regardless of weight change in nutrition state, energy, sleep, metabolic markers and labs, vital signs, cardiac risk, and mood. So we want to continue to focus on how managing the eating disorder in and of itself is also going to result in many of these health outcomes that are the focus often of weight management.
Thanks, Leah. So let's dive in now to the nutrition therapy. What do we do with the initiation of these meds, and how can we support our clients effectively? Let's go to our next slide. Here we've got kind of general nutrition recommendations for the initiation phase. So what we're wanting to help our clients do if they do choose to go on these meds, and we've decided that we want to, help them and support them in that journey to avoid malnutrition, etc. How do we help them to tolerate that initial medication side effects? And as many of you know, clients start off at a smaller dose and then over time gradually increase the dose, that dose tolerance, building up dose tolerance. So with the meal plan, we're going to go back to the basics, small, frequent meals and snacks. We are seeing quite a lot of dehydration with some of our clients. So we definitely want to be making sure that they are drinking enough to ensure hydration. We also want to lower the fat in foods at initiation because we know that, fat takes longer to break down and digest. So that's going to add to even more potentially of this nausea, even vomiting. And then if there is a low appetite, which we would expect because that's what the meds are designed to do, we may even kind of pause the idea of intuitive eating from hunger and fullness, and initiate mechanical eating, meaning that your meal plan is like a prescription and you have a breakfast, you have a snack, you have a lunch, you have a snack, you have a dinner, whether or not you're hungry or not. And we often do that for clients who've had surgeries and various other chronic illnesses. With respect to mindfulness, then, we really want to look at this piece as well with our clients. We want to encourage our clients to eat more slowly, limit mealtime distractions so they're actually really paying attention. So maybe turn off the TV, close the computer, switch off the phone, and then use skills to connect with appetite and thirst. So then what we want to do is how do we make it easier? What do we want to encourage our clients to be thinking of with respect to the types of foods that they're eating? We want to lower that fiber intake, again, for the same reason that we would lower the fat intake. Higher fiber takes longer for the body to digest. So we want to, just be conscious of making sure that that's not too much for the system, especially initially. Limit sugar alcohol. Sugar alcohol, as many of you know, is not digested by the body, and it's in your toothpaste, it's in your sugar-free chewing gum, etc. But if you eat too much of it, it can cause great GI distress and diarrhea. So that could aggravate things. Well-timed fluid intake, we spoke about dehydration being a real risk here, and we would want to go back to what many of you, some of you who worked with weight loss surgery clients back in the day, or maybe still present day, we advise that you have your liquids at different times separate to your meal. Because the problem is if you try to attempt to eat your meal and have liquids at the same time, that bolus, that volume, may make you feel artificially full. And we want to really prioritize the food over the liquid at meal times. Remain upright after eating and also avoid going to bedtime straight after dinner. And both of those are to reduce any kind of reflux GERD type of experiences because that whole motility has been slowed down. So nutrition care during dose stability. So, okay, so hopefully we've worked with the client, we've got them up to their ideal or appropriate dose. And what we want to be looking at here is liberalizing their eating patterns, making sure they have adequate energy, adequate macros, making sure that they're not just eating protein, they are getting some carbohydrate and some healthy fats. We still need some healthy fats. Adequate fluid intake we spoke to. And then, our job, and as Leah laid out, all the different ways we can be monitoring the nutrition state, looking for signs of malnutrition, and also looking for red flags around disordered eating or, in fact, eating disorder behaviors. Over to you, Leah.
So now that we've thought about care, right?
Yeah.
We really wanted to focus in our next slide on how then might we, because I think all of us working in eating disorders, and I would imagine many dietitians and regardless, have some concerns about how these medications might be being used today. And we feel like we have the ability to shape possibly how care is delivered, since there are currently no formalized protocols dictating what best practice care is for these other than dosing. So we want to shape care from the inside. By having relationships with the prescribers in our area and having them to realize by working with us the value that we bring to helping things go better with these clients. So in our next slide, we're going to offer some suggestions for that. One of the things that we were thinking about is this could lead to some challenging conversations, right? Where again, there is a little bit of tension in the paradigms and tension in the goals and the priorities, possibly of teams. And so we sat down and considered how might we have that conversation. And so we provided you with a script here for 3 specific conversations: a client who begins to exhibit eating disorder behavior, or a client who reports significant side effects to you, but the prescriber doesn't know that, or you determine that there is some decline in nutrition state during grip strength is a great example during your NFPE or during your nutrition assessment. And the bottom line is you want to have a script, of course, that's true to you, but these can maybe inspire you. So just as an example, we'll read through number 3, and we'll let you all have the rest of these to take with you. But for example, if we were to see a decline in the strength of a client, we'd want to approach their prescriber with something like, client L's grip strength has shown decline over the past 2 months. Since this can indicate a loss of overall strength and function, I wanted to discuss this with you. I know you want to preserve clients such and such's strength, so that we really, again, redirect back to that shared priorities. And there are ways that we can impact that, right? So Melainie was talking about progression of doses. There's the opportunity to hold with the dose. There's an opportunity to go to a lower dose and see if there can be benefits for the metabolic and glycemic concerns and cardiac risk without having so many appetitive side effects and so much nutrition impact. There are also older agents in this class of medications. This whole class of medications are called incretin therapies, and there are older medications that don't have near the side effect profile that might be beneficial to the client too. So there are options that these prescribers have that they are willing to employ, but they need the data back from us to be able to move that needle a bit. So we're going to wrap up because we wanted to have lots of time for discussion, questions, and answered. And there are some questions in the chat here right now. And I know there's a couple that are really up your alley, Melainie, and I'm happy to chime in too. But we felt like rather than having a summary slide of key points, that this is actually a call to action, because we feel like that we really have to be thoughtful and more proactive with regard to this. So we have some thoughts on what that could look like. The first thing we feel is there need to be protocols for the use of these agents. And this is not something that just dietitians are thinking about. I will tell you, I'm a part of a special interest group that includes a lot of researchers who do research in binge eating disorder and other subsets of clients that are likely to be folks that reach out for these medications. And we all agree that there need to be protocols for screening. I would offer for nutrition risk, but also for eating disorders prior to the even consideration of these medications. So we're advocating that we work with our prescribers to develop some protocols for our clients. Secondly, that screening that we talked about. Thirdly, that dietitians be an essential part of the care. These medications are being touted as something that could replace surgical intervention. And we all know that for clients getting surgical intervention for weight management, that actually dietitians are a key part of treatment. We feel the eating disorder RDs are really in a unique spot to offer something here because of our unique skill set, client interaction skills, and ability to look at that big picture from an eating behavior perspective. And then last but certainly not least, that duration of that isn't a one and done consult. I think that's one of the challenges, is to have advocacy for physicians to recommend long-term nutrition care for no less than 12 months for these clients, so we can actually help them work on initiation and stability and having viable eating patterns that are supportive of overall health, well-being, and eating behavior. And we have one more slide for you. We're almost done. So we just want to give you just a few seconds. I don't know about you, but I get all excited when I come into a webinar and I think about all these new things, and I love to geek out with my colleagues and think differently. But if I don't intentionally make a plan for how I'm going to use that information, it tends to be in a notebook somewhere, or I've made some notes on my computer, and it doesn't always move forward into practice. So we just wanted to give you just a few seconds to consider what's one thing you may try after having time together with each other today. There's some suggestions on here, and I'd offer put some of that in the chat to inspire your colleagues. So let's give you a second for that. And while you're doing that, we'll advance the slides a bit and show you that we have a lovely bibliography for you for everything that we've shown you. There's multiple slides of it. I think there's 2 at least. So you can look up everything we talked about, read the data yourselves, come to your own conclusions. Don't forget to put in the chat those things you're going to do.
I've got a couple of questions, actually, if I could volley them over to you, Leah, to get us started here, that have appeared in the chat. So, Leah, one question was, how quickly do appetite changes typically occur with these medications? What have you seen with your clients?
What I've seen is it's almost immediate.
Yeah.
Literally immediate. Like they inject, and literally within 24 hours, they're noticing changes. And often that's where the nausea and a lot of folks describe it as just feeling ill. Women who've been through pregnancy often will describe it similar to morning sickness.
Yeah. Oh, yeah. Yeah.
Men don't have that
reference point.
But
yes, they're lucky. They're lucky. Oh my gosh, when I think about that, I'm like, oh no.
Right. So imagine living with that for the rest of your life, being told that's what you do.
No. I do know some, I've met a couple of people who are using the medications, and the nausea is just constant. And so they're on like, ginger chews and lots of like those kind of, pregnancy types of things that we used to do. And oh gosh,
bands on their wrists, all the things.
Yes, all of that. Yeah. So gosh. Another question then we have is, you mentioned earlier, Leah, around, if you're finding that these medications and that maybe the side effects are too much for the client, there are older meds that could be a better fit for them. So the question is, what are some of those older meds that you're referencing?
Right. So there's a whole bunch of them, and I'm looking actually for a table that I have. So give me a second to find my table, because I might be able to drop that in the chart.
Yep, absolutely. No problem. While you're doing that, there was a question about what other fast food chains doing and changing, and so I put that in the chat. Some of you may have already read that. Because there's less of a desire for higher fat foods and less of a desire for sweet foods, the fast food chains are modifying those foods. There's more of a preference for higher protein foods, they're finding. So they're modifying accordingly, and also smaller portions. So very, very interesting there, right? There's a question here on what are our thoughts on microdosing? I hear this a lot, Leah. What are your thoughts on that, and what have you seen with your clients?
Yeah, so I've gone to at least 8 educational events that have been put on by experts, in weight loss medicine, that are not eating disorder people. So it's really interesting. Feel like I'm going into territory with folks that do things very differently than my paradigm. But I wanted to see what they were saying and what they were advocating for, which is really interesting. There is no data on microdosing. That is not a thing. It has not been studied. And so when they're asked that question, it's really an off-label use, and there's nothing to tell us if it's useful or not. One of the things I think, Melainie, you talked about in the previous discussion that you had, the last segment here, is that there are so many folks that it's just really hard. It's really hard.
Yeah, because the diet culture is just
It's
so
so
pervasive,
pervasive.
and they're so pervasive. And
So pervasive.
what do we spend as a society? We spend over $80 billion a year. I think it could be higher on the diet industry. So, there's a lot of people who are heavily invested in making sure that.
And I would offer that if you put these medications in there, that number is way out there now.
Oh, absolutely, absolutely. The question here is, how do you help clients meet their nutritional needs when they're not feeling those hunger cues? I think we spoke to the mechanical eating piece around that.
Yeah. And I this is one of those situations where I know this is strong and harsh language, but these medications are actually inducing states that we're seeing in restrictive eating disorders. So
Yes.
we have to then rely on the tools that we use for folks that don't have interoception, don't have those connections to their own cues at the moment, right? So we have to structure them up
Yeah.
and be more prescriptive, which is challenging for individuals, especially if they have dieting histories that might feel very negative to them and things like that, which is again why I believe that we as eating disorder professionals are really sitting in a good place to help people, because we are sitting in the position to be able to hold that dialectic a bit and be able to help guide people
Yeah.
in a better way.
There's any thoughts on trans individuals who are required to lose a lot of weight in order to be eligible for surgeries, who have a long history of anorexia, and who prior to initiation of GLP-1 arrays already have tendencies towards ARFID, which is a disinterest in food, and so they have to kind of force themselves to eat. Absolutely. I'm a therapist and there's a dietitian involved. I'm not sure quite what I'm asking, but more so maybe just venting that this is required. Oh, I hear you. We're hearing about this as well. Part of that weight stigma, not even weight stigma, weight discrimination. And we've seen this over and over with clients needing or supposedly needing to lose weight in order to be eligible for certain surgeries. I'm thinking of, knee surgery as one example, etc. And yeah, what do you do? It feels like an uphill battle, doesn't it? I'm thrilled that you have an RD involved, though. And I think it's one of those things where there's going to be some docs out there who are going to be more reasonable, and there's others who are not. Actually, Dr. Jen Guadiani, I don't know if many of you know, Dr. Jen Guadiani, as a doctor herself, speaks to actually how this is discrimination and actually is maybe not necessary, the weight loss piece. So I'm hoping that we can see more and more doctors advocate against this practice. And I think that we've got to unfortunately lead the charge on that.
I think we are going to
Yeah.
change from the inside too, Melanie, because when you start to think about what that requirement means, you've now impacted wound healing, you've increased risk of infection. I
Yep.
mean, you start thinking about the potential for negative outcomes from a surgical procedure.
Yeah.
to
Exactly.
And delayed someone also when we know if that individual is seeking surgery to feel whole. And if you delay that, I'm sure the therapists on this webinar have a lot of feelings about how requiring someone to sustain living in a situation that is not affirming impacts physical health as well. So there's so many concerns with that.
There
And
is.
just an
Yeah.
FYI, I put a list of the older meds.
Yeah, I saw that. Thanks, Leah. That's
in there for you.
fantastic. There's actually a weight neutral MD student group. So the fact that there are the younger generation MDs out there who are really challenging a lot of this weight stigma, for me is just like, yay. So, advocacy, 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 having those hard conversations with our docs, figuring out the ones who are open and receptive. And then, using the data, as Leah just underscored there, these clients are going into surgery malnourished. That is not good outcome for wound healing, et cetera, et cetera. So much to it. Next question. Have you encountered patients who are utilizing GLP-1s for something other than weight loss, I think? I've heard that there may be some use for them with things like MCAs. Good point. What have you seen there, Leah?
I would say most of the folks I've encountered are working with either very far advanced, almost to type 2 diabetes or metabolic syndrome with a really robust family history of cardiac event, who know that they come from 7 generations of people whose lives were cut short,
Yeah.
and they've exhausted self-care regimen for being able to manage their metabolic disorder. I have not seen a lot of the others, but I know there's also discussion about cognitive improvements and all kinds of things that we're just beginning to see the tip of the iceberg. It's going to be very easy to study just because it's such an amorphous presentation. It's hard to control all the variables. It's going to be interesting to see how that plays out over time.
Absolutely.
Yeah.
And I think Leah, I think what it speaks to, and I want to really emphasize this. My thoughts on this is, as an industry, as a field, I think that we definitely need to educate ourselves about what these meds do and also what they don't do. But I'd like to encourage us to, my first reaction was throw the baby out with the bathwater. I'd like to encourage us not to do that, because there could be these there are certainly ways that these medications are being helpful, and if we can manage the side effects and the symptoms in a way that support the health of our clients, I think many of us are all about that. So I'm not necessarily saying just for weight loss, but one of my clients who had binge eating disorder did a lot of work to get on top of her behaviors and into a place of very good neutrality with food, intuitive eating. She has type 2 diabetes. She also is neurodivergent, so was finding it very difficult to stay on top of daily or twice daily testing and dosing, and was moved on to Ozempic, which was just once a week, and her hemoglobin A1C is so much better. It's actually in the normal range for the first time in years. And it's quite marvelous. And I'm thrilled to see that. She is noting now, over the last couple of months, she said, "Gosh, Mel, my clothing's starting to feel a little larger. I think I'm losing weight." So we're now starting to talk about, okay, well, what do we need to do around that? What are your thoughts around that? Let's make sure we don't get, into a restrictive mode as a result. So I think that's a marvelous example. And so I would like, we just don't know what these meds could support in a way that they were never designed for. They were never designed really for weight loss. It was discovered that that was a significant side effect for what was originally a diabetes medication. So there's a lot more we're going to be learning along the way. One quick comment in our last minute here. The comment is Wegovy has a year-long free support, in inverted commas, team, which I fear does not include RDs. Oh my gosh, terrifying. Any insight on this? Oh my goodness. And insisting that RDs are the experts. We are the experts when it comes to nutrition. No one else has our training. And so it's now at this very early nascent time in this industry with these meds, I think that we need to be really raising our voices, the call to action that Leah laid out for us. And we need to make sure that we're involved in this in the same way that we were with weight loss surgery as part of that initial protocol. We're right on the top of the hour. Love to encourage you to email us if you have any further questions. There's some we haven't gotten to yet, so we'll be sure to respond to those. Wanted to let you know that we're going to be continuing this thread around body image and weight loss. And in the fall, we're going into a webinar series around med spas and body dysmorphia and what's happening with the absolute blow up, at least here in New York, of Botox and this and this and this and the Ozempic face, etc., and really do a deeper dive into body image distress, etc., and what the med spas are doing. So stay tuned for that. And I just want to thank you all so much for joining us today. I'm going to pass you over to Alina, who's going to give you a little bit more information about some of our services. And take it away, Alina. And a big thank you to Leah. That was just, I learned so much from you, Leah. That was wonderful. Thank you for sharing all that knowledge.
We are currently enrolling for our 2-week summer intensive, and we are thrilled that Balance programs are in network with United Healthcare and Cigna. Now, alongside our friends at Graves Nutrition, we'd love to speak on the services that they do offer. With a range of specialized services designed to address complex health challenges, promote recovery, and foster professional development, Graves Nutrition provides expert guidance for individuals, families, and organizations. Their offerings, as you can see here, span from professional supervision and mentorship to specialized training and eating disorder care, business consultation, and individualized nutrition therapy for those facing eating disorders. You can learn more at gravesnutrition.com or call them at their main line at 919 451 0085. Moving on to resources here for your clients or for those who you know are struggling. We run a free virtual support group once a month. This month, our free virtual support group runs from 11 a.m. on Saturday, June 28th, with our intake coordinator, Molly Haney. Clients, loved ones, anyone who would like the support in their recovery can sign up at balancedx.com/free support group. We are also offering our seasonal in-person low-fee support group with Mel at just $25 with limited space. This is an opportunity for your clients to come into the Balance space, tour, get a sense of our team, and see what it would be like to receive in-person support. They can RSVP at the link below. Then we have our free monthly community supervision group for professionals, usually on the first Wednesday of the month at 12 p.m. for clinical case discussion and support. If you're interested, please feel free to fill out the form linked here in the chat. And we'll go on to what's next. We are excited to announce that our provider webinar series is returning this fall. After a successful spring season, we're launching our monthly sessions designed specifically for healthcare and wellness professionals who want to deepen their understanding of body image and eating disorders in their practice. This fall, we're kicking off with a topic that's increasingly relevant in today's aesthetic landscape, the med spa minefield. You can sign up for our newsletter today, and we'll send you a reminder as soon as registration opens for our fall series. Thank you again, everyone, for taking the time out of your day to spend with us. And I'll give the floor here to Melainie and Leah.
Joining us. And I hope that some of those free resources for yourself and the communities might be helpful. Leah, again, thank you so much for joining us. Such a pleasure. And we wish you all well and a great happy Friday. And look forward to hopefully seeing some of you in the fall at our next webinar series. Bye for now.